So we're going to start with Dr. Harris talking about principles of academic wilderness medicine.
Good morning, everybody. This will be very low-key. If at any point you have any questions, feel free to stop me in my tracks and we can address them. Thanks very much to Hillary and Lara for getting this all together and keeping us on task, which is a Herculean effort. So I've got nothing to disclose. I'll be speaking very quickly about an overview of wilderness medicine. So first off, what the hell is wilderness medicine? I'm often asked and have been for the last 20 years, and came up with these two Venn diagrams of resource-limited medicine under austere conditions. And so using those two conditions, we'll talk about ways that wilderness medicine, where it has influence and effect. I'm often asked too, well, this is a brand new specialty, tell me about it. And where was the first school of wilderness medicine? And my argument is that it's not so much new at all, that it started a long time ago on a little island off the coast of Greece when a doctor sat down outside under a tree with a patient, with a student, and Hippocrates founded Western medicine as we know it, and I think really wilderness medicine, and if anything, wilderness medicine is the Ur medicine, the original medicine of paying attention to a human being in front of you, doing a good physical exam, and using your brain rather than hiding behind tests. So it's something that's hugely applicable wherever you work clinically. As far as, I sometimes joke with our fellows, don't pull a Mosley. Wilderness medicine has, I think, at some level been alive and well for a long time. So the good Dr. Mosley was at Mass General, where I come from, in the latter half of the 19th century. And the more I've learned about him, the more impressed I am with the guy. He, during that time, the great learning centers of medicine in the world were in Europe. So he would go study in Berlin for the wintertime. In the summertime was putting up these outrageous first ascents on different mountains. Unfortunately, he had a bit of a bad outcome. But there have been people who've been deeply interested in the mountains and medicine for a long time. So where is wilderness medicine practice? Where are those two conditions of resource-limited medicine and austere conditions in play? In wilderness areas, as defined by the U.S. Congress in '64. In this case, out on the tundra of the YK Delta in Alaska. And also throughout the developing world as a daily course of business here in Nepal after disasters, this here in first world Japan after the tsunami, an earthquake, and then on into the daily care of our hospitals and the emergency departments on the floors and in the ICUs. Why wilderness medicine? Why are you taking a day out of your lives to come and learn about this specialty? It's important in a number of ways, and I think it's a natural evolution of a lot of the way that medicine needs to go to better take care of our patients. So we're expanding access to care. We're bringing medical care to people who can't get to a hospital. So we're providing expert care under circumstances that many physicians would have a very hard time even taking care of themselves. As I was talking about earlier, we're getting back to the origins of any good medicine practice anywhere, and that's the archetypal interaction between two human beings, one listening and paying attention to the one in front of them, doing a good physical exam and using their brain to come up with a diagnosis. We teach efficient care in this age of increasing cost constraint and awareness. Spending a couple minutes and paying attention to a patient can go a long way towards not having to order that CT or MR or lab tests that are expensive and maybe exposing your patient to risk. I often say we go outside to learn to be better doctors inside. Another way that this is, I think, on the vanguard of medicine is we're keeping people outside of hospitals. So if we're developing technologies that allow us to keep people at home or in the field rather than having them evac'd or brought into the ED, that's certainly a win for the patients as my family has gotten older. Coming to the hospital is at the very least a florid pain in the ass, if not actively against the healthcare needs of a lot of people. So if you can keep people in home, in situ, that's a win for everybody. A lot of the work that different groups are working on and that I find particularly interesting is working on innovative technologies. So working with the Department of Defense, with some earth scientists around the world, working on different ways that we can apply existing technologies in an innovative fashion, or we can develop brand new technologies. So things like the optic nerve sheath ultrasonography, the thing on the bottom right there is a portable MR device that, you know, if rather than a tractor trailer sized magnetic resonance device, you have one that's backpackable and you could take to the top of Aconcagua, that would be pretty darn cool. And the DoD feels the same way. Some of the things that wilderness medicine has been good at is pushing that boundary. Just we're very comfortable in places that a lot of people aren't at all. And so if we can move to bring technologies that are in standard use in the emergency department, like ultrasound. So when Peter Fagenholtz, my first fellow, did the earlier work with looking at ultrasonography of the lungs, people were like, that's crazy. These are expensive and you can't take them out of the hospital. And well, yes, you can. And now there's a whole flourishing subtrade in global ultrasonography that really had its origins in people like Peter. Other cool things that I think are really interesting is, again, we're comfortable in environments that other people are not. So if it's high altitude and hypoxia, if it's under the ocean and hyperbaria, if it's extremes of heat and temperature, which with climate change is something that's just going to be a standard that we need to be aware of. So this work that we're doing with Vamsi Mutha and Warren Zapol, they were finding that hypoxia is potentially therapeutic for mitochondrial disease, and they're freaking good at mice and other things, but they said, you know, who can we talk to who does this in human beings? It's like, oh, well, that's Stuart in our shop. And so we're already moving towards doing human trials. The very first research I've done inside the hospital, which is really nice to be able to turn on the light and turn on the heat and flush a toilet. So it's, I feel like I'm moving backwards doing research inside a hospital, but it's fun. Other things that I personally am working on, but there are a bunch of other things that as you talk to all of us today, that you can kind of find where your passion is and where your curiosity is. Would love to develop an actual objective measure of CNS dysfunction on exposure to high altitude. So those are things that a lot of the people here in this room have contributed to and are working on. Again, if we can move forward on the magnetic resonance device, that would be pretty cool to look at potentially traumatic brain injury, traumatic thoracic injury, and other forms of simple edema. And then a lot of our work is looking at the intersection of climate change and human health, and there'll be some talks later this week and then a separate pre-conference later today, really looking at the intersection of climate change and human health. And this isn't something that, gosh, you know, this could happen. This is already happening, and the climate is changing, and it's having population effects and individual patient effects. And so part of the ways we're trying to contribute to that is by supporting world-class people from Woods Hole Research Center and other research groups in the field. And then Dr. Salas, one of our colleagues, is working on some epidemiological studies. So there are a bunch of different ways that you could be involved. Just as a specialty, I think we're especially aware, being outside and being aware of what's changing, that whatever your political stripe, that some rational risk mitigation and awareness is pretty critical to what we do as physicians in advocating for our patients. And so that's something I would be entirely happy to talk to you about. And then we're aware of environmental justice. So the idea that there are very clearly social determinants of health, that where you live and where you go to school and how much money you have, and whether you're next to a highway, all of these things impact your health tremendously. But also maybe if you're on a lowland nation like Kiribati there in the lower right corner, every expectation is that their land will disappear in the next 100 years. And so they're already working towards essentially expatriating themselves to New Zealand and Australia. So it's inevitably the people who contribute least to a problem who are most affected by it, and as moral human beings, we find that repugnant. How do we do what we do? We kind of have the three legs of the stool, as I say it, and then I threw on a fourth leg. I guess I've made it a desk. We teach, we do research, we do clinical care, and increasingly, I think, advocacy and policy interventions are where it's the right thing to do. Anywhere we're doing clinical work, ideally, I would love us to be doing research, and we've kind of pulled that off all over the world. And ideally, if we can be teaching at the same time, we'll reach the holy trifecta. Some days you kind of feel like you're wandering through a bit of a featureless landscape, but it's fun. Teaching, it's great in that wilderness medicine is a great gateway drug for a lot of people. I get a lot of emails from people who, 2, 3, 4 years out of college trying to figure out what they're going to do, take a woofer, and they're like, holy crap, this is what I need to go to med school. And so it's a great entree into patient care and getting your hands on patients, which is what it's all about. But now we've developed a whole spectrum on up through medical school courses, graduate courses, fellowships, and postgraduate CME courses. So we've got a nice range of educational options all along the way. Fellowships are a rapidly growing source of expertise and a way of defining our expertise. We're very well ensconced in the House of Emergency Medicine. There are a few family practice and other programs, and I'm all the more the merrier. I'm an emergency physician. So, and all the programs that I've been most involved with have been EM based. And so it's been a very rapidly growing field, and we're working on training clinician leaders, people who are first and foremost good at the bedside, but then also people who are capable with research and teaching. When I started the MGH fellowship in 2005, it was one of two in the nation. Stanford's was first. We were second. I wasn't aware that Stanford had started one. Give you an idea of how well in communication we were. And as of this last year, there are currently 16 fellowships. So there's post-EM residency fellowships. And at the bottom, you can see there a bunch of meetings tomorrow. But a large part of this spring has been making the argument to my fellow fellowship directors that we need an outside body reviewing the fellowships, and that's moving rapidly ahead. So SAEM has already established a fellowship review committee, so we'll be unleashing that shortly. What else do we do in academics? Sometimes we sit in a dark room and stare at a computer screen for much longer of our life than we should. And we make good friends in the process. And this will be my penultimate slide, but pretty good advice. So Warren Zapol there with the big smile on his face, his peri-retirement age, should have retired a long time ago, is a former chair of anesthesia at MGH. And while he was the chair of this major clinical department, he disappeared to Antarctica for 1 or 2, 3, 4 months a year on NSF-funded research looking at the dive response of Weddell seals. Be happy, smiling, cute, and dive down 800 feet for 40 minutes and come back up happy and smiling. It's like, if you can tolerate that degree of hypoxia, something cool is going on. So I think his go out and do something weird and wonderful and people will love you is pretty good advice. And with that, I will stop, and if you have any questions or at any point, I am at your service. Thank you.